Okay, let's start. So, how can we have better results using OccluSense in our daily clinic in a digital workflow? How can we put all these devices together to understand and to get better results? First of all, we need to understand how OccluSense device works. This is very, very important because we were trained in an analog way for occlusion analysis. And now we are having many, many different devices that capture the occlusal contacts in very different ways. And we are trying to put all these informations together, but we are not having in mind this difference, how they analyze these informations. And so I will start explaining the basis of OccluSense, how it is. It's electronic sensor of pressure. It's really electronic. Here in this sensor, we have electric currents passing through these electrodes, and the pressure of the teeth over these leaves interrupted these currents, and then we can measure this intensity of the contacts. So we have a hardware that through these pins capture the information that the sensor brings us from the contact occlusion, and then all these informations are processed by the app that installed in the iPad. And the core of OccluSense is the sensor. And what is the sensor? This sensor. These two leaves that are turned with electrodes. We have two sheets of a very, very thin material that includes these electrodes. And all these two sheets with the electrodes has a thin of 16 microns. It's a very good acceptable thickness for so many things together. And these sheets are coated with transferable color. This is very helpful because when we get the registration of the contacts, these contacts are transferred to the teeth, and we can correlate it, what we find with the graphics and what we have in the mouth, and we can correlate these informations. These electrodes by these electrodes, we have more than 1,000 points sensible to these pressures. And each of these points are able to provide 256 different levels of pressure. It's a very, very sensible sensor. And for this reason, we get a lot of information. And when we don't know how to interpret these informations, it makes a little bit confused, because as it's very sensible, we need to understand how to filter these informations to interpret them. And these sheets are flexible, and then can modeling the tooth anatomy, occlusal anatomy, to get the intercuspation of these teeth. This is very important, to be flexible, to be able to modeling this occlusal anatomy. And how these data are processed, how they are converted, and how this content and these intensities are converted in graphics. First of all, we need to understand that the colors that we have in the graphic are related to the size of the surface of these contacts. So different from traffic lights, here red are contacts very punctual contacts, very small surface of contacts between the teeth, and are the kind of contacts that we desire, that we are looking for a good occlusion contact distribution. So the red contacts are the more punctual contacts, the smallest contacts that we have. And in the opposite side, in the extreme opposite side, we have the green contacts, the green columns that represent the largest surface of contact. So when I have an optimal and an ideal occlusion, I will find red contacts, red columns. And when I have, for example, a very weird teeth by erosion or for any other reason, we have a more flexible occlusion and with contacts more large. Since we have the height of the columns, after understand this information about the colors that are related to the size of the surface of contact between the teeth, we have the intensity of these contacts. So we have the height of the columns related with the intensity of these contacts. So more intense, more higher, a higher column, and lower intense, lower column, lower higher in a column. Also, and we have some graphics that show us the balance between the quadrants. We have 4 quadrants, and we have the colors. When we have green colors, it means that it's balanced. The contacts, the intensity of the column, the contacts are balanced. And when we have some red color in the graphic, it represents that it's more intense. The concentration of the intensity of the contacts it's greater there in that region. So, and we have for the last the percentages that we can see and correlate with some teeth. Here we have, for example, the second molars and the first molars and the premolars, canine, and the anterior teeth. So we have this distribution, and we can use these informations and this data to understand what is happening with our patients. And before we go forward, it's very important to understand the importance of occlusal contacts. What is really occlusal contacts? The occlusal contacts only happen because we have muscle activity. We don't have contacts happening without muscle activity. So we have a relationship between these teeth, but the intensity and the real happening contact depends on our muscle activity. And this contact also depends on the system stability. I can reproduce the same contacts when this system is stable. When I have an instability of the system, every time that I try to record these contacts, they can happen in different positions. And if I have a muscle hyperactivity for any reason, I also can register different contacts and different intensity of this contact. This is very, very important because we only look and see contacts between teeth, but we forget that we have many other functions that are needed to these contacts happen. And we can check this contact with many different ways. We can use papers, we can use scanners, we can use OccluSense, we can use the softwares, we can use different ways to to see how these teeth are related between themselves. And let's understand how is the importance of muscles. All the function depends on muscle activity. We must have this in mind. All activity, all function that we have in our system depends on muscle activity. This activity can result in balance or unbalance. Yes, if I have a very good muscle activity, balanced activity, I can find a balanced result, or the opposite, it's true. And this balanced result depends on the adaptability of this person. And it's very, very capable of adaptability. It's very, very individual. And we cannot reproduce the same situation for one patient and to the other. We need and we have to consider that patients react, the system react different from one patient to another. This is really, really important, not to put all patients in all the same situations in the same box and say that the same situations will generate the same result. It's not true. The result depends on the ability of adaptability of this system. And to understand what we are looking for, we need to make a very, very good anamnesis. We need to understand the symptoms that this patient is presenting. Which is the discomfort that this patient is presenting. Is there a tooth sensibility? It's a crack, pain, muscle pain, joint pain, headaches. Which kind of symptoms these patients bring us to correlate with what we will find with this different device that we can use in digital flow. And we have to make a very good clinical evaluation looking for signals of unbalanced occlusion. Which are these signs? Cracks, tooth sensibility, wear, teeth, facets, non-lesion, non-cervical non-carious lesion. So we have gingival retraction. We have to look what kind of sign we have of unbalanced occlusion. And then after that, we have this master. If you don't know what we are looking for, you will not recognize what you will find. This is very, very important. I need to use this device. I need to have a question, what I want to look for, and then I can interpret the data in a right way. If I don't have and just put the OccluSense in the mouth, just bite, and I don't know what I'm looking for, it's really, really difficult because this device shows us a lot of information. And if you don't have a question, it's much more difficult to understand, to interpret the data that the device brings us. So how we were trained to analyze the occlusal contacts? We were trained with papers. This is our base line in our knowledge, that are the papers. And how the papers work. Here we have a 200 microns paper, and it's a more thickness of this paper, and it will transfer a more larger surface from these contacts between the teeth. When I go to a thinner paper, you will see that the same contact will happen in a smaller surface because the thickness of the paper is responsible for this size of the contact. And we can see when I use a 8 microns paper, we have a very specific and very defined contact. This is the real contact that it's happening. But what we will see with OccluSense, it's a combination of these marks. As we have a lot of sensitivity from this, yes, Con, would you like to make some question? Yes, I'm sharing. I'm sharing. Just a moment. Can you see the presentation? Okay. It's in the slide with paper about papers. I go back and forward and tell me if it's appearing to you. Can you see when I go backward and forward? I cannot see your chat. Yes. Okay. So these 8 microns contact are the real contact, but these also happen, and we see this combination of different thickness in with OccluSense. For this reason, sometimes we need to use filters when we want to see only 8 microns contact. We need to use the filter to clean these informations that comes from this thickness, this more deep thickness, and to clear and to find this information. Okay, and how we combine the papers? Normally we use a combination of 2 of them. I prefer 100 microns with 8 microns because this paper has a glue with ink that we can mark and we can transfer this glue, and then I can mark very well with 8 microns in any surface because of the glue. So, but what papers register? The paper registers the whole movement that happened. It's a sum of whole movement, the whole movement, and at the end, I have this information. I don't know which contact happened first. I cannot interpret how is the difference, which is the difference between the contacts about intensities. So if I ask you, is this contact more intensive than this? If I ask it will say me that yes, this is more intensity, or for Mark, he can tell me that this is more intensity. I don't know, I don't have some informations with papers. I have just a summarize of the whole movement, all the context that happened during this movement, registered by colors with the papers. What happened with different other digital devices? When I use a software, for example, here it's Mesh Mixer, but I can use any other software, Exocad, Dental System, any other Medit, Link, I can use any other CAD. I will see only the contacts that happen because of the crossing of the meshes. Remember that for scanners, I have a static model from upper jaw and lower jaw. I have these meshes, and the registration of the contacts are made. Remember that I don't have gonfalls, I don't have muscle, I don't have movement in these meshes. Then the contacts that I see are the crossing of these meshes. These are the real contacts that the occlusogram consider and what we can see. What means the other contacts that we can see? Here I would like to put attention on this scale. This scale, it's a protease scale. This is about 1 millimeter. 1 millimeter for occlusal analysis, it's a lot of space. We don't need so much space. And here it's an iTero, and with iTero, I cannot adjust this scale. With some other scanners, we can adjust this scale of the occlusogram, and then we can interpret better. But here I can only consider as occlusal contacts until 200 microns, that is 0.2 millimeters. So all these contacts, blue, clear blue, blue, clear blue, yellow, they are not real contacts, are the distance between these meshes. And we know that for occlusal contacts, more than 200 will not happen. So here I have the real contact that is in red, and the next contact that are in orange, we have the contacts that can happen with when I have muscle activity, gonfalls, and then I can have. So it's not happening at that time, this contact in orange. This happens with all scanners. Why it happens? Because scanners, the occlusogram with scanners are a picture from a moment of this whole movement. We don't close the mouth, the teeth, directly in the maximum intercuspal position. No, we will see that this contact will happen contact by contact until reach the maximum intercuspation. So here it's a frame from a moment of this movement. And for this reason, sometimes I hear from some colleagues, oh, the occlusogram from scanners are not precise. They are precise. The point is that I'm looking just a moment of this whole movement. And this registration depends how I conduct the patients. So just bite, just close, or close with force, to understand and to get the maximum intercuspation position, I need to have the maximal muscle activity, maximum gonfalls, and then I can see and register the maximum intercuspation of this patient. The point is that for scanners, I have to take two pictures. I have to take one for one side and one for another side. And we will see with OccluSense that the muscle are not able to sustain these maximum contractions for a long time. And when I take a picture from this side and then go to the other side, this muscle, it's already relaxing phase. And this is physiology. The muscle has need the ATP for the maximum contraction, and then it starts to release. So we need to understand how these different devices working and use what they can offer in a better way for us. We can combine this information, but we have to understand how they work, and then we can find a common point to put all these informations together. And so here it's an example that I can find the same situation, the same frame of that movement with OccluSense, and overlap with the occlusogram from scan with the scanners. But when we go to what is real happening, we can see that the maximum intercuspation of this patient that I register with the scanner, I can find this position and correlate with all these contacts that I find with scanners. But the point is that this contact don't happen all this contact at the same time. The patient has a way to reach these contacts. And look here that the maximal force, it's not kept for a long time because I need to reach this maximum intensity of this contact, I need the muscle activity. And so for this reason, some colleagues are having so much difficult to interpret the data from OccluSense, because they are trying to interpret this data as we do with occlusograms or with papers. And it's a very dynamic way to see what is happening in real time. And we were not trained to see that. And we need to train our mind and our eyes to understand in real time what is happening. So, and another, as I have said, muscle activity is very, very important. And here I have the same patient, and this illustration, it's very important also to understand how to capture this contact with scanners, and why we sometimes get a kind of registration, a pattern of registration, and with the same patient, sometimes we get different pattern of registration for occlusal contacts. Here it's the same patient with different instruction. Here I told him, please just bite, just close. And look that I have contacts happening in a dynamic way, but here I asked him to close with force, bite with force. The maximal muscle activity are completely different. If I didn't tell you that it's the same patients with different coordination, you will tell me it's not the same patient. This is one patient and this is another. For this reason, when I use OccluSense, I have to know this patient from a very good anamnesis. I have to understand if it's a bruxist patient, how is the sleep of the quality of sleep of this patient, presence of headaches. It's all this information will guide us to conduct this patient when we will making our analysis, because muscle activity will interfere what we will find with this device. And as I mentioned before, the ability of this muscle to keep this contact for a long time is restricted because it's physiology. We cannot keep the contacts for a long time with the maximum muscle activity. These contacts will change because not because are not really real contacts. They change because the muscles are not able to keep them. So how can I interpret this data? I know that this contact, for example, here, that it's not kept for a long time and happen only at the end of the maximum muscle force. I can interpret that this contact, it's real, but it happens only in a moment of this maximal muscle activity. I have to understand this because when I put there and I have this variation with this contact, I think that no, it's something wrong. This contact happened and suddenly doesn't happen. What is happening? Really happening? It's a real or not contact. I have to understand that it's muscle activity that it's registering by OccluSense. And I can use filters to take these contacts off when I want to be very precise with, for example, for adjustment, for a refinement of adjustment. I can use filters to take off some of these information that are not helpful for that situation. And if I have a patient with a good stability of contact distribution, I can reproduce the same contacts when I ask to the patient, close and open, close and open, close and open. When I have this reproduction of the same pattern of contacts, when I ask the patient to make this movement, I can conclude that these contacts are distribution are stable. But sometimes I ask for a patient, please close and open, close and open, close and open. And every time that this patient close, I register a different pattern of contact distribution. This is a sign that this occlusion is not stable. And this is part of our diagnosis. Sometimes we try to find the data that we are looking for, but we are not considering that this patient has not a stable occlusion distribution. And every time that I try to reproduce that same position, I'm not able. It's because the patient is not stable. So if I don't understand that OccluSense is a very dynamic device tool, it's very difficult to think as we think for papers, because it's a completely different situation. And I have also to consider gonphoses and which are the situations that I have in that patients, in that mouth. Why? Because when I have a healthy teeth, I will have a gonphoses happening between the teeth. Normally, the literature brings that for a healthy teeth, we have 100 microns of gonphoses for each teeth. So we have about 200 microns of gonphoses movement in a maximum intercuspation. For this reason, I consider until 200 microns of distance with occlusogram with scanners, because I have a static registration of upper and lower jaw, and I know that with the maximal intercuspation with muscle activity and gonphoses movement, I can reach up to 200 microns of movement of distance from these teeth. So, but if I have an implant in this patient, this implant doesn't have movement, I cannot consider the movement for this implant. And if I have implant lower and implant upper. It's completely different. It's different for, so I need to consider this Gonfal's movement to understand what is happening. And if I have a patient with a periodontal disease that lack a lot of bone support, I will have more movement than 100 microns for this disease. So for this reason, I told, we cannot take the same situations and put in a box. I need to consider many factors that influence the contacts, because the contacts are not contacts by contacts. They depend from many factors to happen. And we need to understand that it's not only about teeth, it's about a system that we are trying to understand how the system is working by this digital device, and also in real-time digital device as OccluSense. So this is the only, until now, this is the only device that can register these functions in real time. Now we are starting with scanners with dynamic movements and dynamic occlusograms. The scanners are bringing this function in their software, but what happens is that we don't have the intensity not yet with the scanners. So the OccluSense, it's still a very helpful tool to understand how the system is working in real time. So I have a clinical case to analyze. This is not a patient in treatment. This is a patient for diagnosis, and I want to make an exercise with you. Here I have a patient with a very good intercuspal position from molars, from canine, very good position for guidance. I have a patient with no facets, very good anatomy, good position for canine from the other side, +1 for molar. So the perfect occlusion, a very good anatomy, okay? And very good anatomy, and what I expected for a case like that, a very good contact distribution of occlusion. So with papers, we have this kind of distribution. It's like a mass, larger contacts with also larger contacts with the thinner papers. So, and here I have the contact distribution, but I don't know the intensity of this contact. I just can see and can say that this contact, it's smaller than this, and then this, and this contact, it's smaller than that. So, but I cannot tell anything more. And when I register with the scanner, here I have a trios, and I have the scale adjusted for 100 microns. So I have the contacts really happening in blue contacts, and in green I have the contacts that can happen because they reach the scale until 100 microns. So during the movement, probably these contacts also happen. And I can compare these contacts that it's perfect. Yes, I can get the same pattern of occlusal contact distribution with papers and with scanners. But let's see how these contacts really happen. This is the maximum intercuspation for this patient. Look that I have a lot of green and yellow columns, exactly what we see here. We have larger surfaces, not punctual contacts, and so I expected that we would have more larger contacts also with OccluSense. And we have a lot of these smaller contacts. What is this? Remember that this patient has a very good occlusal anatomy, and the sensor needs to model this surface to register the contacts. These smaller ones, columns, are not real contacts. They are the surface that the sensor touched during this modeling adaptation. So we can use the filter to remove these contacts that are not real and clean these informations to interpret the data. So let's see how this contact happened. Look that the patient start and go and reach the real contacts that are more punctual, that happens in a smaller surface. And it start and go, and when the patient goes to the maximal force, I have that contacts happening in a larger surface. Why I could find these contacts in the scanner? Because I asked to the patients to close and keep with force. And so I could capture this situation. When I don't know how to orient to guide the patient, maybe I cannot correlate these two devices. Let's see the end of the movement. So close, open, and close. And when I use the filters, look that I have that larger surface, that more punctual surfaces, and I can correlate this with what I found with the scanners. And here I see that I have a good intensity distribution, but the contacts are more concentrated in that quadrant, the right, posterior right. So we can use this to understand what is happening with the patients. And let's see what happens during the movement. Look that the patient goes to the maximum intercuspal position and then it starts to go right, but the whole movement to right, it's supported by a non-balance, the non-working side contact. This is very damaged for the system, and I don't have the movement happen only by canine during the whole movement. At the end, I have the canine, but during the whole movement, I have premolars, I have molars participating of this movement. And look that at this point, I have more intensity on the non-work side than to the work side. This is very, very helpful to correlate with clinical symptoms, with clinical signs that we found at the beginning of our evaluation of this patient. So we have here only at the end the canine making the movement, go back to maximum intercuspation, and for this side, this left side, we have no interference from no working side lasting long. We have a participation of this, but it doesn't last long. But I have the whole movement happening in group with molars presenting a very, very hyper intensity of this contact. It are anchored in molars. So this we can correlate that this joint probably the left joint is suffering from this intensity of contacts. Oh, but you said that we cannot put all the patients in a box. It's real. I can suppose that this patient has a more more intensity of compression of this left joint, and I can look for some damage, but it's not certain that these patients will have a joint problem, but it's normally very correlated. That depends on the capability of adaptability of this patient. Protrusion also have contacts behind and back in the back, and so we can correlate it with the symptoms of this patient. So until here, I hope that it's clear. You have understood the importance of muscle activity, and that occlusion doesn't have as an static phase. It's a dynamic movement that we need to understand, and it works differently for each patient. And now I can show you, I want to show you different clinical applications to how to use OccluSense to help us during the clinic, the different activities in the daily clinic. For oral rehabilitation, when to use for oral rehabilitation, when and provisional and definitive crowns adjustment. This is very, very important because sometimes people, the colleagues try to understand, to use only OccluSense for this adjustment. It's very hard to use OccluSense to the whole adjustment. Why? Because OccluSense brings us a lot of information, and sometimes it's much more difficult to make this adjustment only with OccluSense. It's possible, yes, but it's not the easiest way. How is the easiest way? Is start with papers to check the distribution of contacts, the place of the contacts. And when I say that I'm done with papers, for me it would be okay. Then I started with OccluSense. And then I can adjust not the distribution, but the intensity of this contact. This is what OccluSense helps us a lot. It's to adjust the intensity of the contacts. So my advice to you is not to use OccluSense for the whole adjustment, since at the end for the intensities. These patients arrived to me with a lot of tooth sensibility. She couldn't not brush her teeth because of this sensibility. This erosion was because reflux, and we had to treat it, this reflux together with our treatment. I sent her to a doctor, but we needed to make some orthodontic movements here. And it's impossible to collaborate with orthodontic treatment with tooth sensibility and this level of damage. So I planned some provisional to help her with static, with non-pain, and then keeping the space to the movement here, and then adjusted better than I could this distribution, this balance between the intensity of the contacts to offer her a good a good condition for this treatment. And at the end of orthodontic treatment, here it's the final, the definitive crowns, where we made the adjustments for the contacts distribution. Look that I didn't use filter here. The contacts are really, really very punctual and very stable. And here it's how we started and how we finished. And here it's the patients in a control of 1 year. Look that the contacts are very stable. The patient has a system very stable and working very well and in a very, very good condition. This is very helpful because mainly for oral rehabilitation that we can use this OccluSense registration as a documentation to have a document that how we finish this treatment, it's keeping along the time, and that it's working very well. We did a very good job. This patient uses occlusal splint. She's a very good, very collaborative patient, and treated the reflux. And so we really treated all the causes to reach this level of control and stability. Another situation, clinical situation that OccluSense can help us a lot, it's for occlusal splints. And here I have a case that we have the time 0. And this is how I finish this first adjustment for the occlusal splint. And why didn't I remove these contacts? Because I knew that this patient had a hyperactive muscle activity, and I knew that using this splint, this occlusal splint, this muscle would be better. And then I started, I normally used to wait for this physiotherapy on muscle, with the muscles with the splints. And here it's the same situation, the same patient, the same splint 30 days after. And look how this muscle activity is more clear. And here it's the final adjustment for the splint with no contacts happening. And here it's how the 30 days after, how the patients came with some contacts. This is a lower splint, and with these contacts happening in vestibular cuspide from upper teeth. And here it's how I remove that contact and have this kind of distribution. And OccluSense, it's very helpful to follow these patients, mainly that patient that don't want to use occlusal splints. It's very easy to show them how they disadjusted the splints using this splint, and which would be the consequence in their teeth if they don't use the occlusal splint. So it's a very, very good way for educational to teach them that it's very important, the importance of the use of occlusal splint. And another situation that it's increasing in our daily clinic, it's the adjustment for post-orthodontic treatment, mainly by adding composite to reanatomize the occlusal surface to get a very good stability, mainly now with aligners. Aligners are not able to offer and to bring us a very good intercuspation, and we have receiving a lot of patients that conclude the orthodontic treatment only with aligners, and the occlusion is not stable. And sometimes when we don't have this the power to finish this treatment with fixed with brackets. With for my patients, I'm combining aligners and fixed with brackets, fixed fixed orthodontist, but sometimes we cannot, and we need to stabilize this occlusion. So this is a patient that has a lot of ankylosis, and we couldn't move many teeth of him, and it was a very challenging case because of this ankylosis. But we had at the beginning a very unfavorable position from the canines and some signals happening from this unstable occlusion. And here it's how we finish with a better position from the canines to get a guidance in canines, a better distribution for anterior guidance, but the posterior contacts are very, very poor, very, very poor. We can see here, when I activate the occlusogram, this distribution is really, really poor. We had a lot of facets, we had a lot of non-intercuspidation, and I could not finish the case in this way. So here is the distribution, and here is the OccluSense at the end of orthodontic treatment. It's a very, very poor contact distribution and non-stable occlusion. Look that the maximum that the patient can reach, it's that. So the solution was to add composites to recover this intercuspation. And here we treated with facets and add composite for guidance and an overlay here for this ankylosed tooth. And this is the beginning of the treatment. And here I have a red improving the contacts. You see that this improved at the end. And here it's how I improved the contacts by adding composites. It's lacking a part of the treatment. It's the middle of the treatment, but we reached a very better distribution of this contact only by adding. And here it's the final result with the facets, with the overlay, and a very good stable. We could reach some points to stabilize this position here and here. And this is the occlusogram by 200 microns with the scanner with the 100 microns. But here, look how we got a very, very good distribution and intensity for this case. This case, it's very stable yet. I saw this patient last month, and he's really, really stable and working very, very well. And this is the movements, maximum intercuspation, the right movement, and the left movement and protrusion movement. This is the final result. We negotiated the aesthetic for these two because it has an endodontic treatment, and to wear more structure to get aesthetic, we we thought that were not a very good idea to destroy more structure to get static, but it's a very, very stable situation. So now questions. Here are my contacts. If you have some questions after, I'm available to help you. And thank you for your presence. Now I will open for questions. Now I can read the chat or I can hear you by the microphone.
I don't have any questions, but I appreciate your time. It was a lot of good information. So thank you very much.
Welcome. Coke? Okay. Welcome. No questions? I thank you for the presence, and I'm available for any questions in the future. Bye-bye.